Good afternoon, everybody. On behalf of Acevedo Consulting and Schutz and Bowen, we'd like to thank you for joining us today for the Expect Surprises in the No Surprises Act webinar. Your handouts can be accessed via the taskbar that's on the right-hand side of your screen. And please note that if time allows, we will address questions at the end of the webinar. So just make sure you type those questions in the questions box that's also in your toolbar on the right, and I will get to them if I can with Jean and Tim. I'd like to take a quick moment to introduce our speakers. We have Jean Acevedo, LHRM, CPC, CHC, CENTC. She has over 30 years of healthcare experience and founded Acevedo Consulting in 2000. She has a particular expertise in chart audits, compliance, and education relative to physician documentation, coding, and compliance. Jean has also been an expert witness in civil litigation and a consultant for the DOJ and FBI in federal fraud cases. Mr. Timothy Monahan is a partner in the West Palm Beach office of Schutz & Bowen, LLP, where he is a member of the Healthcare Practice Group. He has practiced healthcare law for over 30 years and represents healthcare providers in a wide range of business transactions and regulatory matters, including resolving disputes between governmental and commercial insurance payers and healthcare providers. And on that note, I'd like to hand it over to them. Thank you so much.
Thank you, Laura. So, hi, this is Jean Acevedo. I'm obviously not Tim Monahan. We are delighted to have such a great attendance at this webinar today. As Tim and I were talking about the need to do this, we both realized that, wait a minute, other than the government doing some, and HHS has tried to do some webinars and send out some other information, there isn't anyone that we knew that was actually doing something that would hopefully take it down to a more practical level. Because this is all new, I am going to go through the disclaimer because it's real important, especially since we have a lawyer participating and lecturing here today. So the information provided in this presentation is intended only to be a general informational summary of technical legal standards. It is not intended to take the place of the statutes, regulations, or formal policy guidance upon which it is based. This presentation summarizes current policy and operations as of the date it was presented, so today, May 20th. We encourage the attendees to refer to the applicable statutes, regulations, and other interpretive materials for the complete and current information. The contents of this presentation do not have the force and effect of law and are not legal advice. This document is intended only to provide clarity to the public regarding existing requirements under the No Surprises Act law. And also, you'll see Tim is going to get started, but you'll notice that we have many components of the law listed on one of his slides. We are, for today's purposes, really going to concentrate on two areas: helping you understand the requirements if you're a facility or a provider that goes to a facility of the balanced billing. I was going to say requirements, but it's actually prohibitions. And then if you're an outpatient office, see patients at home, do telehealth only, for your situation, what are the implications and what do you need to know for the good faith estimate? And with any luck, you all will say, wait, that's not enough, and send in an email to us. Let us know if you would like what I'll call a part 2 that will go over the independent dispute resolution and some of the other things that everybody also needs to know. So on that note, Tim, I am going to turn it over to you.
Okay, great. Can everybody hear me?
Yep.
Okay, good. All right, so before I went to law school, I was a lobbyist. Okay, so and before that, I was a budget analyst in Tallahassee. And you know, one of the things that I like to do when talking about law and regulation is how to get to the root of the problem. What is the problem that Congress was trying to address? Because if you understand the problem as they view it, then it informs how you read the regulations, and it will help you understand where they're coming from. So anyway, so what were they trying to do? They were trying to address surprise billing, okay? Because they've heard a lot from their constituents about surprise billing. And usually when that happens, it's because someone had an elective procedure, they went to a hospital, they were careful to make sure that the hospital was on their list of providers, but they didn't stop to think about the anesthesiologist, the pathologist, the radiologist, all these people in the background who may or may not be on their plan. So you go to the hospital, you have your procedure, you come home, and then you start getting these bills in the mail. So the problem from Congress's point of view is, how do we prevent people from getting these surprise bills? The problem that they didn't ask the next question, which is, why are they getting these surprise bills? Why do we have a problem with people not being on the plan? And those of you who are providers will know that oftentimes you don't join a plan because the rates are terrible, or they don't pay on time, or they question every bill you submit. They didn't ask that question. They just asked the question, why are we getting these surprise bills? Patients getting surprise bills, and that's the problem they're trying to address. So when you start from the wrong premise, you have unintended consequences. Next slide. Can I get the next slide? There, thanks. All right, so the act does a lot of things other than just address surprise billing. But it prohibits providers from directly billing the difference between they would charge and the amount covered in your plan in certain circumstances. It requires providers to give good faith estimates of charges that they intend to, for care they intend to give to uninsured or self-pay individuals. And by the way, throughout the rules, they use the term healthcare facilities and providers, and it's over and over again. It's healthcare facilities and providers. In my mind, they're all providers. So I will often use the shorthand provider when I really mean both. And also throughout the rule, they talk about uninsured or self-pay. Well, an uninsured person is a self-pay. A person who has insurance but chooses not to file a claim, effectively they're a self-pay also. So I use the shorthand self-pay to cover both of those as well. So anyway, so the idea is to protect people against surprises and limit the amount of, therefore, that they can be billed in certain circumstances. Next slide. All right, now, but it's important to know who's not covered here. Beneficiaries in Medicaid, Medicare, VA, TRICARE. Interesting, we've excluded all these federal programs, Indian Health Services, but we included the Federal Employees Health Benefits Act, okay? It's important to know that balanced billing rules do not apply to a provider that doesn't furnish items or services at a healthcare facility. And I'll often, by the way, use services to mean both, or a service that's not furnished at a facility. So maybe occasionally you go to the hospital to see patients, but this particular service, this particular time, you did in your office. The balanced billing rules would not apply to that. But we'll get into good faith estimates. They do apply to that. All right, what else does it not cover? A non-emergency service at an out-of-network facility is not covered. So if someone wasn't careful enough to make sure that at least the facility was on their list of providers for their health plan, they're not protected. Also, if it's a non-covered service at an in-network facility, it's not covered. Okay, so again, we do expect patients to have some understanding of their plan. Next slide. Okay, so what is balance billing? Next slide. And the next slide. Okay, so in general, a non-participating facility must not bill more than the cost, bill the participant, the patient, more than the cost sharing limits of the participant's plan. Okay, so if it's an emergency, the facility is going to get basically limited to whatever the plan says that they can bill the participant, even if they're a non-participating facility. Okay. Also, a non-participating provider can't bill more than the limits of the plan. So you can see where this is starting to kind of hem in providers, and it does represent a power play by insurance payers to try and begin to limit the options of providers who choose not to participate in the plan. Next slide. Okay, so notice and consent. Okay, when can you, if you're in an emergency, if you're a treating provider in an emergency department, when can you, evade, if you will, the restrictions of this rule? If the doctor determines that the person can travel either using non-medical transportation or in non-emergency medical transportation. So if you're stable and you can be transported to a participating facility, then then notice and consent is not required to be treated at the non-participating facility. Okay, and there's notice and consent rules there that basically tell you what you must do if you're a non-participating provider at a participating facility. You have to tell people, hey, these providers we have at the facility, you can choose one of them, and that will be on your plan, covered on your plan. And if that is if the person doesn't want to choose another one, a participating provider, if the patient doesn't want to, then it becomes an obligation of the non-participating facility to give a good faith estimate. Next slide. Okay, so when does the notice of consent not apply? Okay, if it's a non-participating provider and something comes up, okay, so you get informed consent to treat the patient even though they know you're not on their plan, but then something comes up that's unforeseen. Okay, once again, the non-participating provider is going to be limited to the patient's plan, so there's another example where the providers are getting hemmed in on their options. And of course, records must be maintained for 7 years. Next slide. Next slide. Okay, so this is balance billing for non-emergency services. Okay, so the greatest restriction is when it's an emergency service. Okay, if it's a non-emergency service, these are the rules. A non-participating provider at a participating facility who provides a covered non-emergency service, right, must not bill the participant for more than the cost-sharing limits of the participant's plan, unless you satisfy the notice and consent. Okay, so there's notice and consent. The idea is to give the patient the option to waive their protections if it's an informed consent. And that's the same concept of informed consent as you get for a surgical procedure. Same kind of idea. All right. So, but this is a list of services that for which consent or can't be given to waive. You can't waive your rights for these services, right? Emergency medicine, anesthesiology, pathology, radiology, all these, hospitalists, intensivists, diagnostic services. These are all the facilities, all the services that take place in the background. So again, if someone chooses to go to a facility that is on the list for their plan, they are protected for surprise charges from all these providers that are operating in the background. Next slide. Okay, now how do you give notice and consent? How do you get someone's consent to waive their rights under the law? You got to give it to them in writing. It can be paper, it can be electronic, but it's got to be in writing. Now, when do you have to give it? Okay, if it's a scheduled service, scheduled data service, right? Not later than 72 hours prior, you must give notice and consent if you're a non-participating provider. If the appointment is made at least 72 hours prior, you got to give the notice at least 72 hours prior. Okay, of course, that doesn't answer the question, what happens if it's 73 hours late prior that the appointment is made? There are aspects of this that are just not practical.
Hey,
Okay.
Tim.
Yeah.
Can I ask you a question for some clarity? So
Sure.
if I'm the patient's in the hospital and I'm called in consultation, I'm the cardiologist, I'm the palliative care consultant,
Mhm.
and I'm not on the patient's plan.
Right.
Does this applies to me? If of course I want to bill them my normal charges. Does this apply to me?
Yeah, I think so. If it's a participating facility,
Yeah. Assuming all those things are in place, participating facility, patients, that's the plan the patient has. But
Yeah.
I'm a consultant called in, and it's not an emergency, right? Which of
Right.
course it precludes me from even trying to get consent, right? So
Right.
okay, so all those consultants have to be concerned with this. Thank you. I just wanted some clarity on that.
Yeah,
Appreciate
no,
it.
that's good. Thank you. All right, next slide. All right, so consent, of course, must be voluntary, and it must not be revoked prior to the service. Okay, and you've got to get a signed consent. So if you're not on the plan, make sure that the patient understands you're not on the plan, and you get the consent. Next slide.
Whoa.
Go. Okay. All right. What has to go on the notice? You're a non-participating provider. We'll get into the GFE, but later, the good faith estimate of expected charges. But it's important to note that it's not a binding contract. So you're required to give it, but it still doesn't lock in the patient. Which is pretty ironic. Okay, and you're required to inform the participant that they may have to get prior authorization from the participant's insurance. Now, mind you, you're not on the plan, so you don't know the requirements, but you're just required to tell them, hey, you better check this out. And you're required to tell the participant that they have the right to seek care from someone who's on their plan. And if they do that, then their cost sharing responsibilities will be limited by their plan. Next slide. Okay, so anyway, here's a lot of detail about the HHS form, and you know, it reminds people that they have agreed to be treated by a non-participating provider, that they understand they may be balanced bill, and you've got a document when you gave the notice and when they signed. Next slide. Okay, so this is provider and facility requirements regarding patient protections against, this is disclosure requirements, excuse me, against balance billing. Next slide. Okay, so this gets into the content of the disclosure, and these disclosures will are designed to, you know, inform people of their rights. All right, so the part of the disclosure goes over the information that we covered on the previous slide. Okay, if there's any state law on the subject, you know, you have to inform them of any state law protections. Okay? And that's important. In Florida, for example, we have a statute that's in the hospital law, which was adopted in 1992, which was designed to address many of the same kinds of issues as this No Surprises Act was designed to address on the federal level. So it's important to make sure that you're aware of the requirements in your state laws. Okay, and you have to tell people who they can complain to if they think there's been a violation. Next slide, please. Okay, so here's where you disclose it. On the website, on a sign at your location, and on a piece of paper, or either in person or mail or email. And the participant gets to decide how they receive that information. Next slide. Okay, so now this is kind of interesting to me. It says, when do you give the disclosure? When and this is one of the things that it really doesn't make any sense to me. You know, when you request payment, well, that's a little late to be giving the disclosure. I have to think of this really as the second notice. You know, what you publish on your website, you know, what you put on the sign on the wall, what you give to the patients. You know, that I would look at as kind of the first notice, and I would kind of look at this as the second notice, reminding people of their rights. That's open to interpretation. But otherwise, it doesn't make sense to me that the first time you're disclosing something to somebody is when you're asking them to pay for it. Anyway, now here's two exceptions that I think are important. Okay, so these balance billing disclosure requirements do not apply if you never furnish services at a healthcare facility. They do not apply if your services, if you do go to a hospital from time to time, but maybe these particular services were furnished in your office. In those instances, there's no balance billing disclosure requirement. Now that is not the same for the good faith estimate, and we'll get into that later. All right, so and then here's they did something practical, commonsensical for doctors that do a lot of procedures or a lot of work at hospitals. The hospital can agree to post and meet all these disclosure requirements on behalf of both the hospital and their doctors. And if they agree to do that and they fail to do it, then it's on the facility, it's not on the provider. Next slide. Okay, so balance billing for air ambulance services. Suffice it to say that if a patient's plan covers air ambulance services, then all air ambulance, say that 3 times, services are required to honor the patient's plan. So those folks in the air ambulance service business really got the short end of the stick on this part, because they essentially have no control over what they charge patients. Next slide. So the good faith estimate. Okay. Next slide. And this, the good faith estimate is designed to, again, alert people that if they're choosing a provider that's not on their plan, they may have some surprises in the bill. And the good faith estimate is then designed to basically disclose in advance to the patient, you know, what the provider expects the patient will see in terms of charges. Next slide. Okay, so again, what is the definition of an uninsured or self-pay? It's an uninsured person, of course, is someone who doesn't have health insurance. Okay, a self-pay is well, an uninsured person, as a practical matter, is a self-pay, right? But a self-pay also refers to someone who has insurance, but for whatever reason doesn't want to bill insurance for that service. And sometimes people do that for privacy reasons. So as a practical matter, they're both self-pay in those instances. Next slide. Okay, now here's some definitions that are important. A convening healthcare provider. What is a convening healthcare provider? Think of that as the person who's going to provide the primary service. And by the way, item and service I covered with the term service. So whoever's the main reason why you're going to the doctor, that person that's providing the main service, that's the convening provider. Anybody else who's involved in providing that service is a co-provider, co-healthcare facility co-provider. Okay, the expected charge is what you know would normally be well, basically your charges on your fee schedule. Okay, the good faith estimate is the provider's attempt to tell someone, hey, I'm not on your plan, and this is what I estimate. You know, this whole process is going to cost you, and the convening provider is the lead dog here, and the convening provider is the one who's supposed to pull all this information together, not just his charges or her charges, but the charges of everybody else who's involved in the service. Okay, healthcare facility, we know what that means. Healthcare provider means physician or other healthcare provider or the facility. Next slide, please. Okay, so items and services, which I call services together. It's soup to nuts of everything that a patient gets billed for, essentially. All right, period of care means the day or the multiple days that the services are going to be rendered. So pre-op, post-op, imaging, lab, everything that goes in, everything that must occur within a day or a period of days for the service to be complete. Okay, again, primary item of service is why you went to the doctor in the first place. Uninsured, we've covered that. Next slide. Okay, so what does a convening provider have to do? First, you have to ask if the patient has insurance. Okay, and if they do, do you want to file a claim? Okay, so if you don't have insurance or you don't want to file a claim, then you're self-pay, okay? If you're self-pay and I'm not on your plan, then I got to give you a GFE, good faith estimate of what it's going to cost.
Hey,
And
Tim.
yep,
Tim. So
yep,
in practical perspective, I want everybody who's listening to
yeah,
understand.
help me with that.
The biggest impact for y'all is to think about who gets that initial call. So I'm calling to get an appointment with my primary care physician, my rheumatologist, the dermatologist, the orthopedist, and everybody at that, whoever is going to make my appointment needs to be asking me these questions, because as Tim goes on, you're going to see that there are time constraints under which you have to give me the good faith estimate. So I think one of the largest hurdles for providers of all types in this law, in the outpatient setting, right? He talked about balance billing, inpatient, right? This is now outpatient, your office, doing home visits. I know a lot of clinicians are now doing nothing other than telemedicine, telehealth. So in all of those situations, and if an uninsured self-pay patient calls for an appointment, that's who this individual is, and how are your staff going to know to ask these questions? Because one of the things we're not going to go into today, just as in time, don't want to keep you all here with us till the end of the day on a Friday, but it's like the independent dispute resolution process. Tim briefly mentioned that patients can complain. Shocker, right? So know that this is going to be, for the most part, from a practical perspective, going to be impacting your first person who speaks with the patient. So keep that in mind as he keeps on talking about the requirements for this. Thank you, Tim.
Yeah, thanks. No, that's really important. Yeah, because you do have to, you do have to pay attention to this from the first phone call. Okay, so if someone asks for a good faith estimate, you give it to them. If they ask anything about cost, the law considers that a request for a good faith estimate. Okay. If they're not on the plan, you got to give them a good faith. If you're not on the plan, plan on giving a good faith estimate. Okay. Now here we get into the deadlines. All right. Upon the request or within 1 business day of scheduling, you got to contact all the co-providers and ask them to give you their good faith estimate information, and you give them a deadline. Next slide. Okay, a convening provider must provide the GFE to self-pay within these timeframes. Okay, if the service is scheduled at least 3 business days before the service, you got to give them the estimate not later than 1 business day after you schedule it. Not after, not before the service, but it's keyed from the date of scheduling. And then here you see if it's at least 10 business days, if the service is scheduled at least 10 days out, you've got to give them the estimate within 3 business days. So you see, you really have to be on top of this, and the people that you work with, the co-providers, they've really got to work with you to help you meet these deadlines. So if there's a change in the scope, you got to notify people of that. And if there's a change in the provider, there's some protection for the patient there too. In other words, if you change providers less than 1 business day before the date of service, the replacement provider has to accept the GFE of the person he's replacing. But that is another going to be a surprise for a lot of doctors. Next slide. How are we doing on the time, Jean?
So you have, I think, maybe one more slide after this, and
Okay.
then I'll take over. So we should be
okay. All right. I don't want to run on.
Yeah, no, I'll just have to speak in my fast New York mode.
Okay. Well, my wife says I can run on sometimes, so I check. All right, so if a GFE is provided upon request, upon scheduling, then you have to comply with the deadlines that I just went over. Okay. Now, here's one thing that they did that's practical, and that is if you have a recurring set of services, you can give a single good faith estimate. Okay, as long as it doesn't exceed 12 months of time. So that's actually kind of practical. Who knew? But of course, if the recurring set of services related to treating this chronic condition or whatever is going to take more than 12 months, then after 12 months, you've got to update the good faith estimate. Next slide. Is that Eugene? No, I still have it. Okay. So, okay, here's some more deadlines. Deadlines for co-providers designed to help the convening provider meet his or her deadlines, okay? A co-provider, if you're a co-provider, you've got to reply within 1 business day. And you got to give a new GFE if you, think of something that's going to, that you didn't anticipate in the first place. And again, if there's a change in the co-provider less than 1 business day before the date of service, the replacement co-provider has to accept the GFE of the prior provider. Okay, so again, the whole idea is to try and prevent surprises to the patient. So if the patient has seen the GFE and they're relying on that, and then there's a last minute change in the provider, this is consumer protection. It's designed to protect the consumer, even if it's unfair to the provider, quite frankly. And of course, here's something that just really caught me by surprise. If a self-pay requests a GFE from a co-provider, suddenly that provider is a convening provider. And now that doctor or facility is responsible for checking on and getting the estimates from everybody else. So it seems duplicative, it seems unfair, but it's the law. Next slide. Okay. Important. The GFE is part of the medical record, and it's got to be kept for 6 years. And you've got to be prepared to give out a copy if it's requested anytime within 6 years after the service. Okay. And then, if there are state rules that they don't meet federal rules, that doesn't work for you. Next slide. Okay, Gene.
Yep, so here's where I'm gonna kick in. Let's see if I have control. Just check it so I don't have to, whoops, where did it go? Sorry, folks. Let me make sure. Nope, this isn't working.
All right,
All
I'm
right.
sorry, Jean. I handed it over, but I guess we have a glitch this time. So just let me know when I need to change it.
God bless technology, internet gremlins, as I call it. So, all right. So, Tim talked about 2 things, right? The balance billing, or the prohibition against balance billing. If you're seeing a patient in a facility, inpatient, right? Whether emergency, non-emergency, what cannot do as far as billing the patient if you're not in their plan. And then secondly, what are some of the requirements for, okay, now the patient's coming to see you, right? And they're uninsured or self-pay. And as he pointed out, the uninsured, if they're paying you, is actually self-pay. So, and then he ended with what the convening and co-convening providers need to do. I'm not going to read each one of these bullets in this slide and the next one or 2, but I would like to point out that one of the 3 handouts you guys have in the handout section of your GoToWebinar toolbar is the actual form for a convening provider to use. But as you'll see, as you look at this, there's a lot of information that is expected that if I'm paying out of pocket, not a Medicare patient, not Medicaid, not TRICARE. Remember, Tim went over at the beginning, all of those third-party government payers that this doesn't apply to. And if you think about it, that makes sense. If this isn't a covered service and I'm a Medicare beneficiary, well, Medicare already has its rules and steps that you're to take, right? ABNs, et cetera. So for those commercial, managed care, ACA plans, and the Federal Employee Health Benefit Plan, that's not covered. I'm out of pocket. This is the plans that those are the plans that this typically includes. So all of this, Laura, next slide, please. All of this information must be on the good faith estimate. Laura? Hello, did I lose you? There we go. Your expected charges. So now, some of you who may know me know that I'm an ex-practice manager. So I look at this from a real world perspective, and I don't have a clue how I would be able to figure out what you, if you're making an appointment to come see one of my providers that I'm working for, what were your expected charges? Know that as long as you're in a range, you should be okay. Any penalties or the ability for the patient to instigate a complaint and the dispute resolution process only comes into play if the good faith estimate you gave that individual is $400 or more. I'm sorry, yeah, the actual charges are $400 or more than the good faith estimate. Right? But then it's the name of the providers and the facilities, their office locations, their tax ID and NPIs, et cetera. It's an unbelievable amount of information that no one has today that I'm aware of. Now, the kind of good news, as you're sitting there, probably eyes very wide right now, is that HHS, Health and Human Services, understands that there is some time needed for providers and facilities to actually implement processes, right? So just do it. Don't worry too much this year as to whether or not you're spot on. But you have a PDF handout of HHS's model or sample good faith estimate document. I can't imagine why you wouldn't use that, especially at this point in time until all of us get to know more. Next slide, please, Laura. And let me see. Oh yeah, all these disclaimers need to be on it. Next slide. Okay, so I'm a co-provider, and I'm glad Tim pointed out the fact that if the patient reaches out to me to find out what my charges are, suddenly I'm a convening provider. Boy, talk about a convoluted thing. God bless the folks in Washington. So the co-provider has to provide all of this information to the convening provider. So I've gone to the dermatologist, and maybe I'm in between jobs. So I don't have health insurance until I've been with my new firm for a certain number of days. So it will kick in July 1st. Let's just use the day. So I go to the dermatologist. I've got a weird lesion. And so I'm self-pay, right? Just don't happen for this period of time to have health insurance. And when I call to make the appointment, staff are going to need to be able to ferret out for me why I'm coming. And then because I'm concerned, it would be reasonable to think that I might need a biopsy. So that would be a procedure the dermatologist would do in addition to his or her evaluation management service. If there's going to be a biopsy, there needs to be pathology charges, which may be an outside dermapathology lab. What if this type of complaint I'm calling with leads the folks to believe that, oh, wow, I wonder if she's got is going to need Mohs surgery. If you have a Mohs surgeon in your practice, you have to add those costs, et cetera. So I use that one example for some specialists. I could give others that are along the same lines. Think orthopedist, endocrinologist for a new diabetic or a thyroid patient, et cetera. So know that you have to consider all of that. And the biggest hurdle, as I had referenced before, will be spending the time to work out the processes in your organization to be able to get the information when a patient is scheduling an appointment, and provide the good faith estimate within the time period that is required. Next slide, Laura, please. Okay, now what I'm going to do, because I just wanted to end with that, now what I'm going to try to do is to, for the two areas we've discussed, the balance billing and the good faith estimate, to bring it down to more, again, of the practical level. Now, as Tim mentioned, this is brand new, so nobody really knows all that much. We're trying, right? We've read, we've discussed, and in fact, Tim and I have had many a discussion as we've parsed through all this language, preparing for you all for today. But so I've not made up these knowledge check questions or FAQs. I've gotten them directly from the HHS documents because my perspective is typically that until there is something interpretive that's out there to rely on, I don't want to put anything that the government already has in my own words because semantics can mean something. All right, Laura, let's go to the first balance billing here. So here's a scenario. Zoe, and I didn't make that up. My dog's name is Zoe, but it's with a Y, but this is the government's example. Zoe is a 26-year-old female with Marketplace, so ACA insurance. She works as a teacher, has an average knowledge of health and medicine. She has severe pain, swelling, and redness of her right calf, becomes concerned that this may be dangerous, so she travels to the local hospital emergency department that is in her health plan. So we're talking about the balance billing, right? She has a venous ultrasound. The radiologist, who is out of network, reads the ultrasound, which shows a deep vein thrombosis, so the patient is started on a medication and discharged from the emergency department. Do the No Surprise Act balance billing protections related to the emergency services in this situation apply to her and the radiologist? Next slide, Laura. Yes, it would. She sought care for a medical condition that, using reasonable layperson judgment, she thought was an emergency medical condition that needed immediate medical attention to avoid serious jeopardy, impairment, etc. And according to the No Surprise Act, out-of-network providers are banned from balance billing for emergency services. So again, when Tim was talking about the form, the disclosure, the consent to get the patient to agree to allow you to balance bill them, excuse me, it's not for emergency services. Next slide, Laura. Carlos is a 62-year-old male with employer-sponsored health insurance. He is, bear with me one second, my little thing here is covering up my slide. He is involved in a motor vehicle accident and sustained multiple injuries. He's taken to the closest hospital, which is out of network. He has surgery to repair multiple leg fractures. Once he's stable and out of surgery, he is counseled on the option to transfer care to another local in-network hospital for the duration of his recovery. His treating physician determines the safest form of transportation, and which would mean in this case he'd be airlifted. Would be via ambulance. The patient knows that the hospital he is in has an excellent reputation, wishes to stay there for his recovery. The hospital provides a written notice for the balance billing and gets his written consent to waive his balance billing protections. And he remains inpatient for 2 additional days and eventually discharged home. So since he decided to stay in this hospital where he was initially admitted as an emergency, does the No Surprise Act's prohibition on balance billing for emergency services apply to all of the days that this gentleman received during his hospital care? Next slide, Laura. Yes, the hospital is banned. So again, counterintuitive. Excuse me, the hospital is banned from balance billing for items and services provided prior to his being stabilized. The hospital is also banned from balance billing him for post-stabilization services provided after surgery, despite obtaining written consent from the patient to waive his balance billing protections. Because he could only safely be transferred via ambulance, the hospital cannot seek consent for him to waive his balance billing protections under the No Surprises Act specific to post-stabilization. So it's not like he could have a family member pick him up in the car and take him across town to the other hospital where he could continue care. Next slide. Sean is a 35-year-old male who has insurance has ACA insurance through the marketplace. He's playing soccer, sustains a knee injury, which is diagnosed as a torn ACL. He is advised by his friends to go to a specific orthopedist who has an excellent reputation. His surgery is scheduled at an in-network ambulatory surgical center a week in advance. One day before his surgery, he gets an email with the written notice and consent documents informing him that the orthopedist is out of network and requesting that he consent to waive his balance billing protections under the No Surprise Act. Sean signs the consent to waive his protections as he would like to see the specific provider for his knee surgery. And then weeks after he gets home, he gets a bill. Did the orthopedist comply with the requirements of the No Surprises Act? Next slide. Nope. The provider violated the no surprise requirements related to when notice and consent documents must be provided. Sean scheduled his surgery more than 72 hours in advance. Written notice and consent must have been provided to him no later than 72 hours before the date of the appointment. And in this case, the provider sent notice and consent documents one day before the appointment. So it's not only figuring out, depending on, we have all different types of specialty providers, facilities attending this. You have to look at your own particular situation and the specific situations that will come up for you, right? So because all requirements relating to the notice and consent exceptions weren't met, the surgeon is banned from balance billing Sean for services provided as part of the surgery, even though he signed the consent form. So it's not only knowing what circumstances you can give the consent, it's also then making sure that, and we didn't even go over the content, right? We won't today, right? So making sure the content is there and that your timing meets the law's requirements. Next slide, Laura. All right, so that's just for some clarity and to challenge you with the things you're going to have to think about in your own organization. Let's take that perception and apply it to the good faith estimate. So now you're not admitted to, your patient isn't admitted to a hospital. They're coming to your office or clinic. You're going to their home, assisted living facility. You're sitting in your home office doing nothing but telehealth. No real facilities involved, no hospitals, no ambulatory surgical centers. Next slide. So let's go through about 8 or 9 FAQs. First of all, which providers and facilities are required to provide a GFE to uninsured or self-pay individuals? All providers and facilities that schedule items or services for an uninsured or self-pay individual or receive a request for a good faith estimate. So guys, wait until the general public gets wind of this. Excuse me. Must provide that individual with a good faith estimate. No specific specialties, no specific facility types or sites of service are exempt from this requirement. And understand where Tim and I have both been clear and tried to make sure you understand that the balanced billing impacts commercial health insurance, ACA, marketplace plans, federal health employee benefit program, but not Medicare, Medicaid, TRICARE, the VA, etc. This is payer neutral. These circumstances apply to that person who is going to see you, get care and treatment from you, or at least is arranging for it, when they are in a situation that they're either uninsured or self-pay, one way or the other, paying out of pocket. Next slide, please, Laura. Do providers or facilities need to provide GFEs to all individuals, for instance, patients with Medicare or Medicaid? Well, let's see if the government answers this the way I've been talking. Effective January 1 this year, providers and facilities are required to provide GFEs to uninsured or self-pay individuals who schedule items or services or request it. An uninsured individual is one who is not enrolled. Everything I just said. A self-pay individual is one who is enrolled in but not seeking to have a claim submitted. And under the No Surprises statute, providers and facilities are generally not required to provide GFEs to individuals insured under Medicare, Medicaid, or other federal healthcare programs, obviously, except for the Federal Employees Health Benefits Program, right? So I was delighted when I found this FAQ that my interpretation was right. Next slide, Laura. In what forms must the GFE be provided? I've had questions from some folks I've had the pleasure of working with saying, well, we'll do it, we'll give it to the patient over the telephone. Nope, that won't suffice. And the main reason, if you were to read this FAQ, is that should the patient, the individual, decide that, wait a minute, they didn't tell me within the time period, or the amount they told me was $700 less than what the charges actually were, and they want to take you, file a complaint and take you through the independent dispute resolution process, there needs to be this document, right? Similarly, even with HIPAA, I've always been a proponent of patient wants their medical records, et cetera, have them put it in writing. Don't keep them from getting their records timely, but there are timelines, right? That you have to comply, et cetera. Same thing here. So the GFE must be provided in written form, either on paper or electronically. Electronic transmission of the GFE through the convening provider's patient portal or electronic mail. For those of you on an electronic medical record in the Part B world, right, professional services world, where you have, excuse me, an electronic medical record, excuse me, that has a patient portal, this is a great use of the portal. You know, for some of the quality programs, excuse me, being able to support that the patients are using the portal, this helps you in more regards than one, right? But of course, it's a matter of in what manner that the patient asks for it, right? So the patient is at the center here. So if a patient requests that the GFE information is provided in a format that is not paper or electronic, like orally over the phone or in person, the provider may provide the GFE information orally, but must follow up with a written paper or electronic copy. So having it on documented, some form of hard copy, and make sure it's dated so you can know what the date of the request for the appointment was and the date that you're giving the GFE. Next one, Laura, please. Why must a GFE be provided in writing to an uninsured or self-pay individual? So hopefully this says just what I was talking about. A paper or printable electronic copy of the GFE is integral as it is required input for the patient-provider dispute resolution process. Yep, that's it. And the individual can use it if the actual bill charges exceed the GFE by at least $400, right? So yes, it's you wanted to give it in some form of written hard copy format as a CYA, if nothing else. Next slide, Laura, please. Do providers or facilities need to provide a GFE to uninsured self-pay individuals who have zero financial responsibility? So I had actually seen this question in an HHS document a few months ago, and I put myself immediately on a quest to see could this possibly be right. I'm the vice chair of a healthcare charitable program here in Palm Beach County, Florida. I have the pleasure of working with many providers, whether it be physician offices, hospices, health systems, et cetera, who are not for profit, or even if they are for profit, excuse me, have certain policies or arrangements where they would never charge the patient. So I was literally shocked to find that the government expects that even in those circumstances, because the patient is uninsured, that a GFE is expected. So here's the answer about, do you need to give that to a patient who will have a zero financial responsibility? Yes. All uninsured or self-pay individuals who schedule items or services or request an estimate must be provided a good faith estimate. A GFE is required even if the uninsured or self-pay individual has no estimated financial responsibility because the actual bill charges for the item or service is not guaranteed to be zero. That's not me saying it. That's the government saying there are no guarantees. Many of you know that that is a fallacy. And a GFE is required to initiate the patient-provider dispute resolution, blah, 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 what we just said, right? So understand that it's not just the example I gave of the patient who's, just started a new job, her group health insurance won't start for a month. She comes to you for care. So she's self-paid today. She's also uninsured today, or the patient that says, no, I don't want to run this through my insurance. The cosmetic procedures that certain specialties provide, right? It's not just those. It's also where you would not be charging. So I guess you have to give a GFE that says 0. The only logical thing that I've been able to come up with for this scenario is, okay, so your organization doesn't charge patients for their care or services or items, but is there a chance that you would refer them to the local imaging center, right? And would they have potentially have an obligation or the chance to be receiving charges from that entity, right? So, because remember, if you're the primary entity that the patient is seeking care from, as a convening provider, you must seek out the information about costs, services, et cetera, from those co-providers that would be reasonably. The only thing that in this wording that gives me any faith is that it talks about it would be you're required to give the patient the individual charges that could reasonably be anticipated. Next slide, please, Laura. What are the GFE requirements for co-providers or co-facilities when co-providers or co-facilities may not have complete information from the other providers yet? So a co-provider and co-facility are required to submit GFE information to the requesting convening provider or facility, which must include, among other things, the expected charges that are reasonably expected to be provided in conjunction with the primary item or service. Excuse me. They must be sent to the convening provider, and Tim mentioned this earlier, no later than 1 business day after receiving the request. So it's Friday. You're the radiologist, and the office who's scheduling the patient for some service for next Wednesday knows that, well, we're probably going to need an MRI or a CT scan. So they reach out to you, the imaging center, to get your charges. And if you look at the form, please don't look at it when we're still talking because you'll pull your hair out. You'll realize that it's the type of service, including, if you can, the CPT code that represents what the charges will be coded as. The co-provider, so the imaging center, it's 1 business day. So on Monday needs to get back to you. Don't worry, nobody has to work over the weekend. That's the only kind of good thing here. Next slide, please, Laura. What are the GFE requirements for co-providers when providers or co-facilities may not have complete information from other providers or facilities involved during the period of care? In the event that an uninsured self-pay individual separately schedules or requests a GFE from a provider or facility that would otherwise be a co-provider, and Tim talked about this a few minutes ago, that provider or facility is now considered a convening provider. So if you're that radiology group, you're the pathologist, and I've reached out to you to find out, okay, I know I'm going to need this. The doctors told me when I called to schedule my office appointment. I want to get to them and see what their charges would be. All of a sudden, that ancillary provider is considered a convening provider. And this will be real interesting to see how this works in the real life. Next, please, Laura. How can providers provide a good faith estimate to a self-pay individual when the underlying complexity of an individual's condition is not yet known? This, to me, was the part of the crux of the problem with these good faith estimates. So let's see what the government says as of now, at least, right? So the good faith estimate that's provided must include itemized list of items or services grouped by each provider or facility reasonably expected to be furnished for the primary item or service, and items or services reasonably expected to be furnished in conjunction with it, right? So remember what I said probably 20 minutes ago, sitting down with your staff who schedule appointments, who get inquiries from patients, about your services and working out what the flow will be, what their script will be, what form they need, what will pop up on the computer in front of them when they're dealing with either a new patient or someone who's self-insured, self-pay or uninsured today when they're reaching out to make an arrangement to be scheduled to see one of you is going to be, I think, the highest hurdle for all of you. The interim final rule does not require the good faith estimate to include charges for unanticipated items or services, right? So if I go back to even my dermatologic example, so I've got a lesion, I'm not sure what it is. Okay, so probably it'd be reasonable to expect that I'm going to have either a biopsy or have it removed. So my office visit with the dermatologist and whichever one or both of the procedure codes for the removal. But it probably wouldn't be reasonable for the doctor to anticipate that what I, as a layperson, am thinking about as just a funny little lesion doesn't look good, that's going to be a melanoma, then I'm going to need, more care. So thinking through all of that is going to be important, as well as sitting down, whatever group within your organization can do this best, and thinking about, okay, what are the top 5, top 10 reasons that people reach out to us for an appointment? So if it's because they're diabetic or think they have diabetes, you're going to have that office visit and at least a blood draw, right? If you do labs in your office, it would be the office visit, the blood draw, and the reasonably anticipated clinical lab test that the doctor knows he or she would want for that condition, et cetera. That's the best way, I think, to handle this. Have your top 5, top 10 conditions and make some a form, because remember, it has to be something documented given to the patient that is also used as a script for the intake staff. Next slide, please. Must the GFE include a diagnosis code? So when you look at the form, and if you were to look at the slides that I brought in showing what the forms require for information, you'll see that it asks for CPT HCPCS codes, ICD codes, etc. But if the provider does not know the patient's diagnosis at the time of scheduling that initial visit, and do you have to report it? No, right? So this would not be reasonable, right? So that was one reasonable response. Next slide, Laura. For recurring items and services, does a good faith estimate need to be provided for each instance? And Tim addressed this a little. And for this, I think about physical therapy, right? Any type of rehab where the patient is going to be scheduled for X number of visits, right? Anything like that. So the answer is no, right? Where the provider expects to furnish recurring items and services, periodic counseling services, physical therapy, a provider or facility may issue a single GFE. I also think about, I work with a lot of rheumatologists, so patients who are scheduled every number of weeks or every 6 months for certain infusible or injectable drugs, the doctor knows exactly how often, right, that drug is to be administered. So could indeed give a good faith estimate for the course of a year so that patient and the office don't have to keep dealing with a good faith estimate every time the patient calls. Okay, I think that was it for the things that I wanted to point out with the governments. Yep. So Tim, any final comments that you want to make to this illustrious group who's spending a Friday afternoon with us?
Well, as I go through this, I'm hearing what you're saying about practical strategies, and I do think that we're going to have to help people think through practical strategies about contracting in situations where, as a practical matter, it's just not practical to be out of network. And how do you address those, and how do you bring pressure to bear on your hospital if you're in the hospital to use their cloud on your behalf to make sure you get decent rates, because you're going to get roped into accepting other people's plans. There's a lot of things like that I think we will have to think through strategically you know, as people as who are providers and who are, you know, trying to see how to navigate this without getting beat up too bad.
Yeah, no, for sure. Laura, do we have any questions that came through when I was talking that we could take a couple maybe before we turn off?
We actually have quite a few questions, Jean. We'll try because I know we're getting short on time, and I apologize for that. I'll do two. How's that? And everybody else,
Okay,
if you put a question in, I'm going to put these in front of, I'm going to get them in a spreadsheet, put them in front of Timothy and Jean, and we will get back to you on them. But I'm going to keep them short and sweet, Jean, if you can, if possible, with this subject. But here's the first one from Geraldine. If a patient's insurance is verified before scheduled data service and after the claim is filed, there is a COB issue. Can we bill the patient our self-pay rate? After the claim is filed, there is a COB issue. Sorry, can we bill the patient our self-pay rate?
That's okay. So this, what we've been talking about today would not apply. The patient made their appointment as an insured individual. And so none of what the No Surprises Act deals with is applicable to that scenario. And without knowing whether or not you're contracted with the plan, et cetera, and what the service was, I don't think we could provide an answer, sorry, to the question. Excuse me, but yeah, because that's going to be with whatever the coordination of benefits was, or plus, as I said, you have, if I understand the scenario correctly, the patient made the appointment and the provider's impression was that it was an insured patient, right? This is only in the outpatient setting for uninsured or self-pay patients. And when you know that, not a year later or 6 months later, et cetera. Sorry. The next one, Laura.
Okay, yes. What if the patient is unresponsive? Does the consultant not see the patient?
Hey, Tim, since sounds like it's an emergency in the inpatient setting, you want to take that one?
Yeah. I mean, if they're if right, I think that's the key there, Gene. You know, if they're unresponsive, it indicates it's an emergency setting, and you know whether or not you're the on the plan or not, you're going to be limited to that person's plan's cost sharing limits.
Right, and I wouldn't, and I'm not sure who's asked the question or what specialty, et cetera. So sounds like it's probably not a dermatologist. So I think that most physicians, non-physician practitioners would know that clearly it depends on a lot of the circumstances. But if I'm the neurosurgeon on call, say, and the patient's unresponsive and there's no one else other than me, I wouldn't want to be that doctor who didn't see the patient because they weren't sure whether or not they'd ever be able to balance bill, right? So I think there's a lot more ethics involved in that than this topic in particular. So, all right, Laura.
Thank you, Jean.
She will capture the questions in Excel, get them to myself and Tim to give you the best answers we can with the information that we all know today. And I would also, excuse me, sorry, I woke up with something this morning, wrong day to wake up with some tickle in my throat. So also, we would be willing to do a part 2 if there's interest, right, for the areas that we could not have discussed today. And I think you wouldn't have wanted us to in one day. So thank you also very much for attending. We appreciate your interest and your time. And here's wishing that you all have a wonderful weekend.
Thank you, Jean and Timothy. Everybody, take care.
Bye-bye.